I just want to say thanks everybody for joining us. My name is Dominic Roto. I am faculty at the University of Rochester. And on behalf of the Pulmonary Circulation Assembly and my co-editors at the PC Assembly Journal Club, I want to say thanks for joining. Today we're going to be discussing a recently published article by Dr. Sandeep Sahay. This was published in Chest, and it's entitled The Comparison Between REVEAL Lite 2 and COMPERA 2.0 for Risk Stratification in Pulmonary Arterial Hypertension. So the format for today, we'll first start with a brief overview of the article by one of the authors. This is going to be done by Dr. Nelson Hernandez. Afterwards, we'll have a discussion led by our group of expert panelists. So we're really fortunate to be joined by the first author, Dr. Sandeep Sahay from Houston Methodist. We also have Dr. Mardi Gomberg from George Washington University, Dr. Raymond Benza from Mount Sinai, and Dr. Jim White from the University of Rochester. After the discussion, we'll use the remaining time for questions. So for the audience, as questions come up, please feel free to raise your hand or put them in the chat, and we'll field them in the order they come in. So with that, I'm going to turn things over to Dr. Hernandez.
Thank you, Dr. Roto, and good morning, everyone. Thank you for the opportunity to present our paper. Give me 1 second to share my slides. All right, I think everyone should be able to see them now. So like Dr. Roto said, we're going to discuss the paper that was published in Chest last year, comparison between REVEAL Lite 2 and COMPERA 2.0 for risk stratification in PAH. Here you can see the full list of authors. So as we know, risk stratification is the cornerstone of the management of PAH. And in 2015, the ESC/ERS guidelines recommended implementing a comprehensive risk assessment in patients with PAH that included these clinical assessments, exercise testing, biomarkers, imaging, and hemodynamics. This model was then abbreviated and validated in cohorts such as COMPERA and the Swedish PAH registry. And in both of these cohorts, what they found is that most of the patients were categorized as having an intermediate risk. And this unveiled the need for a more sophisticated tool. And it led to the development of the COMPERA 2.0 four-strata model that had more refined cutoffs for functional class, walk distance, and BNP and NT-proBNP, and split basically that intermediate category into intermediate low and intermediate high. This model is now recommended by the 2022 ESC/ERS guidelines to be used at follow-up, and at baseline, they still recommend the three-strata model. So in this analysis, we compared the REVEAL Lite 2 calculator with these COMPERA models, both at baseline and follow-up to better understand the prognostic capabilities of these tools. To do this, we performed a retrospective analysis of consecutively enrolled patients with PAH between June of 2011 and February of 2022 in the PAH registry at our expert center at the Houston Methodist Hospital, and we included patients with incident and prevalent PAH with confirmed diagnosis based on the 5th World Symposium with the hemodynamic definition that you see on the screen. And we collected their data at baseline and first follow-up. We had a total of 342 patients in the registry that had that first visit within that time range, and 46 of them were excluded due to a missing data point, whether it was a functional class, walk distance, or BNP, NT-pro, BNP that didn't allow us to calculate the risk score. So in the end, for the baseline analysis, we included 296 patients. And then at follow-up, we lost about 100 patients due to unavailable data. All patients were stratified according to the COMPERA models, both the 4-strata and 3-strata, and the REVEAL Lite 2 scores were calculated. And we basically took REVEAL Lite 2 both as a continuous variable, meaning as the actual numerical score, and then also as a categorical value variable as low, intermediate, or high risk. We used Kaplan-Meier curves to present the outcome event at 1, 3, 5, and 7 years from the first visit. And this outcome event was a binary outcome of all-cause mortality or lung transplantation. The performance of each model was determined using the C statistic, and the comparisons between the C statistics were conducted using the discrimination improvement And we also had ROC curves to predict this binary outcome at 3, 5, and 7 years for all models. And the areas under the curves were compared using the chi-square test. So going into the results, we see first the demographics of our registry. The median age at the baseline visit was 53.5. Most of the patients were female with 85%. Over half of them were white. And we did see that 42% of them had PAH associated with connective tissue disease. Regarding their treatment at baseline, we see that the majority of them were either on dual or triple therapy at the time of their baseline visit. On the left side, we see the overall survival of the whole cohort, which was 68.8% at 7 years. And on the right, we see the risk stratification that was done at baseline. So for this, I will focus on the 3 strata, which is the one recommended for the 2022 guidelines, and then REVEAL Lite 2. So when we see the stratification based on the 3 strata, we again see what was described previously of the bulk of the patients being categorized as intermediate risk with 76%, followed by 14% in high risk and 9.5% in low risk. And when we look at REVEAL Lite 2, the repetition between the categories seems a little bit more equal, with 38% of them being low risk, followed by 31% being intermediate risk and 30% being high risk. We then plotted those Kaplan-Meier curves to see the patient survival. And in this figure, this is based on the risk stratification with COMPERA 3 strata. And we do see distinct survival curves for each category that were and these differences were statistically significant. With at 1 year, the overall survival for the low risk category was 100%. It was 95% for the intermediate category and 81% for the high risk category. And we do see that decline over time with the high risk category going all the way to 23% by about 6 years. And here are the survival curves based on REVEAL Lite 2. And again, in these curves, we also saw distinct survival with statistically significant difference. At 1 year, patients who were categorized as low risk by REVEAL Lite 2 had a survival of 97.4%. The intermediate had 95% survival, and the high risk had an 86.6% survival that went all the way down to 38.2% at 7 years. Then this is here we see the C statistics for all the models and their comparisons. So the first row, which is the continuous REVEAL Lite 2, is the one where we saw the variable as the actual numerical score, and it had the highest C statistic with 0.74, followed by the categorical REVEAL Lite 2 at 0.72, and then the 3 strata had a C statistic of 0.63. And since we're talking about baseline, and these two are the ones that are, since the 3 strata one is the one that is recommended by the guidelines, we can compare it to the REVEAL Lite 2 and see that there was a difference of 0.12 compared to the continuous REVEAL Lite 2 and of 0.07 compared to the REVEAL Lite 2 as categorical. And both of these differences were statistically significant. Here we see the ROC curves for each model for the overall outcome at 3, 5, and 7 years. With again, the highest AUC for all time points was for REVEAL Lite 2. And again, these differences were statistically significant. We also plotted these Sankey diagrams to see the overlap in risk category in between risk models. In this slide, this is only based on the baseline risk assessment. So again, on the left side, in the comparison between REVEAL Lite 2 and the 3 strata model, we again see that a lot of these patients were in the intermediate risk by the 3 strata model, and they were some of them were actually low risk by REVEAL Lite 2, others were intermediate, and others were high. And then on the right side, we see the overlap with the four-strata model. And here, it basically gets a little bit more trickier because, again, there's more categories where they can overlap. Then we basically perform the same analysis at follow-up. And here I'm going to focus on the four strata since it's the one recommended by the guidelines, and then its comparison to REVEAL Lite 2. And we saw that at follow-up, when performing the risk assessment, 50% of patients were categorized as intermediate low by the four strata model, followed by 31% who were categorized as intermediate high, and then 15% were low risk, and only 2.6% were categorized as high risk, compared to REVEAL Lite 2, where 41% of the patients were categorized as low risk, 31% as intermediate, and 26.5% were categorized as high risk. Here are, again, the survival curves for 3, 5, and 7-year survival. These ones are based on the four strata model. And we, again, saw significant differences in survival in between the groups. Here, it's important to point out that the curve for the high risk drops significantly, but also we had very few patients in that category. If you remember, it was only about 2.5% of the patients were in that category. And here we see the survival at 3, 5, and 7-year for patients as stratified by REVEAL Lite 2. And again, at 3 years, the patients who were low risk by REVEAL Lite 2 had a survival of almost 94%. Those who were at intermediate risk had a survival of almost 90%, and those who were at higher risk had a survival of 53%. And then when comparing the C statistics for these models at follow-up, we saw that the REVEAL models maintained the same C statistic. It was also 0.74 and 0.72 at baseline. And the COMPERA models actually improved a little bit. Now the four strata has a C statistic of 0.70, which would only be a difference of 0.02 in when compared to the categorical REVEAL Lite 2. And as you can see, the p-value was high, so this difference was not statistically significant at follow-up. So in this paper, basically showed that REVEAL Lite 2 showed better risk discrimination at baseline compared to the COMPERA 3 strata, especially when used as a continuous score. And that for follow-up evaluation, REVEAL Lite 2 and COMPERA 2.0 appear to have a similar risk discrimination. And some limitations of the study include that it was a retrospective single-center analysis and the fact that we lost about 100 patients at follow-up due to missing data. So that's all for me, and I'll turn it over to Dr. Godo and the panelists.
That was great. Thanks, Nelson. So I'll now turn it out to our panelists to kind of talk about what they think are the high points and how this kind of could be practice adjusting, or how they kind of place this data in the context of patient care.
Well, I just wanted to start because I know that my colleagues speak a lot, so I figured I should start it off. I want to first point out that the analysis was done with patients that didn't have missing data because of COMPERA's derivation, where you can't have any of the missing data, which I think is interesting because I wonder what the REVEAL Lite 2 would look like if we just included everybody, and how much power that would bring, or if you guys did a sensitivity analysis on it to see if it strengthened your score. But I do think that that's a fundamental difference between the two. I also think that as someone who's helped develop these risk scores over a long time, the cohort that you're using matters. So this REVEAL Lite 2 was derived from a cohort that's going to be more similar to Methodist cohort than COMPERA cohort, which is very different from the types of patients that we see here in the US. And so to me, the equation that you should be using is the one that's going to be the most similar to your patient cohort as a clinician. So it irrespective of the statistical value and strength of REVEAL Lite 2 for sure over the COMPERA 3 and showing it also in follow-up. I just feel like this cohort and cohorts in the US, we should be probably using REVEAL Lite 2 just for that reason alone on the derivation of the equation.
Yeah, I think one of the things that I found particularly interesting in this evaluation, and we've seen similar things in a large database that we've created with the FDA, is that these changes in C index, which are significant, really means something. I've heard a lot of arguments about what's the value of having a statistically significant difference in C indices, and I think you can see that very nicely on the Sankey diagrams, because you can see how the COMPERA system overestimates intermediate risk, which could lead to the inadvertent use of medications that are not necessary. But even more importantly, on the flip side, there's a number of patients who were deemed high risk by REVEAL, who were deemed intermediate risk by COMPERA, in which potentially a prostacyclin, parenteral prostacyclin, may not be used. So I think that shows the importance of those statistical differences when you're looking at the rate of discrimination. And at baseline, I think it's probably the most important decision you have to make, because this is really setting the patient's trajectory for the next year, which is where most of that attrition is. You could see in those Kaplan-Meier curves that the slopes change very little after a year. They all remain in the same direction. So getting it right at the beginning, using a highly discriminatory score to make sure that you're using the right upfront therapy, I think is intimately important for our patients.
I think, Dominic, there is a question in the comments.
Yeah, so we have one question so far. So the question is, it seems that the 4-strata model only considers as high risk at follow-up very few patients from your cohort. And as compared, for instance, with REVEAL Lite 2, have you analyzed this difference and why it exists? I'll throw that one out to either Sandeep or Nelson.
You're right. I think that some of that has to do with the definition of high risk that the Europeans have at 20%, right? Risk of death at a year. And so it's a higher bar, which I'm not really sure why they chose such a high bar of mortality. So I was actually wondering, you guys didn't adjust it based on which score you used, correct? You just used what each score used as their normal high risk.
Yes, yes. What we saw in this was that the intermediate high risk by the COMPERA 4 was pretty much the same patient, which is high by REVEAL Lite 2. And one can make an argument, because if we look at the guidelines and European evidence also, they basically say that intermediate high should be treated as high risk, and which is what REVEAL Lite 2 is highlighting them as high risk. So I guess clinically, perhaps you could be more aggressive in that patient population who is intermediate high or remaining. I don't think management-wise there should be much more difference. However, if you look at the low risk patient population in the REVEAL Lite 2, if you look at the Sankey diagram, I have it up here, unless Nelson could pull the slide up. There's a significant chunk of low risk by REVEAL Lite 2 was intermediate low risk. And Nelson, do you have the survival? I think we looked at it, right? It was not significantly different. And I think that's one point I wanted to highlight, that even if they are they were low risk by REVEAL Lite 2 and they're intermediate low risk by the COMPERA 4 method, I think their survivals were not different, right? Nelson, do you have that
Yes.
slide somewhere?
Yes, I'll just have to pull it up in a second because that was in the supplement. But we did look at the survival in those who were low risk by REVEAL 2. We compared those who remained low risk by 4 strata and then those who were intermediate low. There was no difference in survival. And then we also looked at those who were intermediate risk by REVEAL 2, those who were who overlap with intermediate low in COMPERA, and those who overlap with intermediate high risk in COMPERA, and we didn't see a difference in survival either. You give me a second, I can pull up the.
So basically, COMPERA made it more complicated, but fundamentally because they used the
Audio, you got muted.
Sorry. I feel like that if they just changed what they called intermediate risk and high risk, then they lose the differentiation, but it's like they made it harder and more complicated when they didn't need to make it so complicated. And then I guess my other question was, you in your paper when you did the 3 strata and then you looked at it in follow-up, you were just looking at it as a comparator, even though it's not recommended, correct?
Yes, I was just looking at it as a comparator. Yeah.
And then my last question to you guys, since is that in the demographics, I think the majority of people are on at least 2 therapies when they
Yes.
were enrolled. So I just know for REVEAL and for our old data set in Chicago, it was like the baseline cath was your diagnosis. And so the majority of people weren't on drugs at that point. And I was wondering if there was like some timeline, like they were just started and then you cath them, because it might affect some of the numbers.
You're right, Marty. I think because unfortunately, as you know, the history of our program that also moved from Baylor to Methodist. So we had our access of data was limited to the Methodist system, which is last 10 years. So we kind of lost a little bit. So our baseline was more like what FAR registry has, like the time you start care at our place, So you're right. So these patients may have been prevalent. They're not like incident patient population, but of course, cumulatively over the years, whatever, we had some incident patient population. But you're right. That's a caveat there. It's not truly an incident. The baseline is baseline for our center, but baseline doesn't really mean they are newly diagnosed PAH patients. Yes, that's true.
One of the things that I thought would have been important to do in this particular study, and I guess you can do it in the future, is, at baseline, when a patient has just come through their diagnostic evaluation, they really have a very comprehensive data set that includes, their hemodynamics and echocardiograms and their PFTs. And since COMPERA 3 really uses the entire dynamic table as part of their stratification system, I think using REVEAL 2.0 at baseline would have been a better comparator to the COMPERA 3, because you had all those variables in the beginning, and it's important to use every tool in your tool belt when you make those initial decisions.
Actually, Ray, thanks for bringing up that comment, because we can actually do that now, because since pandemic, we have REVEAL 2.0 in our EMR flow sheets. And so all the new patients who come in the beginning, we are like clinically, we are doing that. So I think we can certainly do that now. And I don't know how much will be the volume of patients, but certainly can be done. That's a good point. We can look into it.
Hey, let me ask you guys a question. I came in late, but so in case somebody's already asked this, I apologize. So once again, this is another set of data that show that REVEAL in its various forms, especially Lite 2, is seemingly the best on the block, right? Okay? And yet, as much data as we create, okay, we cannot convince, nor I don't know how we are going to convince the guys on the other side of the pond that this is so. Okay? So how do you go about convincing people that even though the science is better, you can't convince people? I mean, part of the problem is this amazing schism between the US and the rest of the world as to which one to use. So how do you go about dealing with this or convincing it?
I mean, I think first we just need to educate folks here,
But we,
like doing this. I
Marty,
know, but I think we don't have, folks, when folks give CME and refer to the European guidelines as COMPERA and don't stress that you're using REVEAL and why you should use REVEAL, especially in North America, then we
yeah,
perpetuate it.
I don't disagree with you, but we've been perpetuating it now for years now, right? No, I'm just bringing it up. It doesn't, even though we're generating more and more data, it just doesn't seem like we're making a hell of a lot of progress here.
I think the one of the rationale to do the analysis was pretty much what Marty highlighted in the beginning, that the patient population is different, demographics is different, and second, like our reveal was derived from the US patient population, and many of us use that in our clinical practice, and if the guidelines are recommending something different, then we are kind of left into a situation where we don't know if what we are doing is totally accurate or is it good
But
or
wait,
bad.
Sandeep,
Well,
we've applied the Reveal 2 to the European databases, it's still better, right?
I'm just saying we're providing the real
No.
world data.
So you can't get around the argument that it's wholly different because if you apply it to their database, it's still better.
Yeah, the Go Deep registry, was really the first global registry to compare all the uh, tools,
Yeah.
really unbiased data set, meaning that none of the groups that participated in Go Deep, the patients were not part of any of the derivations of any of these scores, and on a head-to-head basis, the same pattern emerged.
Yeah.
In fact, that paper actually had very interesting hazard ratio as a continuous variable for reveal. I can't remember the numbers, but with each score going up, how much the hazard ratio also increases. So
For Sandeep, knowing that some of the data is sort of not first presentation
yes,
cath, and still being able to demonstrate the utility, I think is a benefit of the paper, a strength, because we all know that registry data is registry data. In addition, that practices are different and patients get referred at different times. I rarely get patients not on therapy. They're often cathed on the outside, and I would imagine that that's similar in many places, unless you're really the feeder, or get lucky and happen to pick it up early and do that cath before you've been started on anything. So I think that that was a real strength in the paper. I feel like we get bogged down on which is best, and I think that in cardiology we're using lots of risk assessments, right, all the time. You know, we standard are looking at risk of stroke with AFib as a perfect example. We know how the equations have been derived, and we don't really argue it across the world. And I think in a rare disease, there are differences in patient cohorts, perhaps more than looking at AFib with, 30,000 patients. And that's why we're getting some of this differences. And I think that we just have to sort of take the high road which is what we do every time. But we need to be strong when we're teaching that this is why we're using it. I don't know. We've already done this, Steve, in the cohort of all of our FDA trials, I think. Maybe not in the complete cohort, but we definitely have done it in some of the studies.
Yeah, I mean, Steve and I have the luxury of having this data and compiled and harmonized it, and in the evaluations that my team has done with this 4,500 patient data set, which really is a global data set. It's from all over the world. The patterns are even more robust in terms of level of discrimination and significance and discrimination, and the over and underestimating of risk and what the consequences of that are. We just need to get it published.
Dominic, do you have any more questions, comments?
I was wondering what Jim thought since
I've seen him mute and unmute a few times, so
Yeah, I'm not.
He's got
I
that
guess-
continuous smirk on, so I was wondering what his face
No,
would
no,
be
no, no,
to
no,
do.
no. Not at all. Hey, everybody. I'm. First of all, I guess I am not certain about how important it is that we, continue to produce data that says that a more refined. I mean, obviously, when we use REVEAL as an ordinal, this is just the age-old argument of whether you're a lumper or a splitter, right? Like there is more refinement in the ordinal gradations of whatever use of REVEAL, whether it was REVEAL 2.0 or REVEAL Lite. If you use the ordinal scale, you'll have more gradations, and that's more refined, and your predictions are going to be better. And Ray, that is especially true when we started to look at hospitalization, which we should definitely be looking at, things that are less bad than death. So that's, I don't know that it matters so much to me. I also think the fact that REVEAL uses, EGFR has been one of the most potent discriminators in outcomes, and it makes sense because it's assessing something that matters on a variety of levels, right? And that's not in COMPERA. For me, there's two things that I'd like to see us start to move ahead to the next level. One is what do we miss in REVEAL that's really important? And I think that, lots of us are interested in figuring out how to incorporate imaging of the RV into this, right? And because imaging of the RV really is the holy grail of how we predict and how we do this as clinicians. And we still miss that. And I think a very important loss in the scores that we haven't been able to figure out how to overcome, and that I'm trying to produce data to show is that the people with inappropriately silent NT-proBNPs, those with NT-proBNPs less than 300, whose right ventricles do not look like NT-proBNP less than 300, that's a really important need that we have to define how many people there are in that. And I think it's 10 to 15%, and figure out how to close that gap. I think that's one important need in the field. And the other thing that I'd like to see us start doing better is really looking at the change from baseline to follow-up. And Steve and I have had this wrestling match that I think it's if you're a REVEAL 6 at time point 16 weeks or 24 weeks or whatever time point into your therapy you are, I think it probably matters a lot whether you started out as a REVEAL 8 and got down to 6, or whether you started as a REVEAL 6 and stayed at 6, or REVEAL 5 and went to 6. And I think figuring out how to incorporate the trajectory into future decisions is really important. And obviously, Ray, that's something that you guys are looking at in FORA. So I think for me, the argument about whether, the guidelines that our colleagues across the pond are so good at producing, whether COMPERA or REVEAL is better, I think as Ray says, it's kind of been settled, and I don't feel the need to argue about it anymore. Looking forward, I'm really curious to see these two gaps filled. One is, how do we do better on incorporating trajectory, which I bet we all agree is important.
how do we quantify and incorporate trajectory? And secondly, how do we fill this gap for these people who have inappropriately low NT-proBNP? I'll tell you that for the PROSERA study, the emphasis on NT-proBNP and REVEAL Lite 2 is excluding a lot of good participants because that silent NT-proBNP gets them -2 REVEAL. And all of a sudden, somebody who's very obviously a great candidate for PROSERA is not, because that's so heavily weighted in REVEAL Lite 2. So that's my diatribe. I was smiling because I enjoy you all, not because I had any smirk.
There's some.
Certainly not because of the Bills.
We live in Rochester, not Buffalo. We only sort of care.
It's all the same. Yeah, so really nice presentations, interesting data. I mean, I think the big question out there to pull back is, how do we react to these predictions? Does HAP do something differently than Marty does after applying these prediction rules? And dare I say, does it improve outcomes for the patient using these predictions? So I think there's probably a lot of variability, based on given the same REVEAL score or COMPERA score, lots of variability within, between individuals, centers, continents. And I haven't seen that kind of analysis, but maybe someone on the call has or has done it.
So you're
That's a great
suggesting a
point,
decision
Steve.
analysis question?
Yeah, I mean, number one, how uniform are we as a community in responding to predicted risk X, either at baseline or follow-up? And does that translate into improved outcomes?
Yeah, that is the question, Steve. And what the final part of the R01 that we're doing now is the development of a risk registry in which clinicians are afforded the opportunity to use risk stratification tools or not, and then pattern the behaviors based on whether they use them or not and what the outcomes are. So I'll be asking a lot of you people on the phone whether you want to participate in this registry or not. And we've actually had some preliminary conversation with the PHA whether we can do this as an ancillary study with FAR, because that registry is so well developed already. Could we incorporate a component of risk stratification into FAR to see if that type of risk stratification behavior does indeed improve outcome? Because that is the most important question that we haven't answered.
I would argue the other thing that we haven't done is patient voice in it, because we are not factoring in cost of 3 medicines, quality of life, and true, not just quantity of life. And I think that none of our risk scores do that. None of us have been really thinking about it. And I mean, I'm all for looking at RV imaging and getting the RV back to normal and including as many patients as possible. But, I think that patients do and don't tolerate certain medications, but also sometimes they just tough through it, because I see it with my IPF folks that are on those meds that are making them feel miserable, but they think if they're going to stop it, that they're going to decrease their survival. And so with that balance, I think is more important now that we start actually trying to figure out a way to incorporate that as well.
Yeah, we tried some attempts at that. In fact, Nelson is working on some of those PROs, incorporating that into the new stratification system that we're building with the FDA. We tried to answer some of those questions when we looked specifically at the Ambition trial. And I think we published this several years ago that, low-risk patients who were on dual combination therapy actually there was a percentage of them that had a poorer quality of life because of the side effects of the medications, without a huge benefit in outcome, either determined by mortality or morbidity. So, are there people who, because of their quality of life, should still receive monotherapy? Is it, a question in my mind too.
Ray, I think you're exactly right. The question we don't have to answer when we look at our REVEAL scores and whether we're making treatment changes is what's the burden of treatment on our patient population? And the things we ask our patients to do, I don't know that all of us would be willing to do.
Of course not. I was actually going to say pretty much what Marty said, but I was going to add, in answer to what Steve said, the only data that are at all available that I know of that are actually relevant that go way back to the original REVEAL registry, in which it was looked at what happened when people deteriorated from functional class 3 to functional class 4, and most of the providers did pretty much nothing. They didn't change the regimen at all. If you looked 6 months later, the regimens were barely changed, if at all. So it is a good point that it is great to have the score, but if you don't react to the score, taking into account what Marty said, that the patients can only tolerate so much medicine. Okay, that's part of the problem, is that, and other patients will tell you, I mean, all of us have had this experience, I'm on enough meds, I'm not taking any more.
Well, I would love for, Steve and Marty and you guys to help Nelson figure out this. But we have all that PRO data, and I would love help figuring out how to incorporate that. So if anyone has ideas, please, Steve or Jim, Marty, John, please reach out to, Nelson and Sandeep, and I will try to figure this out, because it's better working with a group than it is in isolation to kind of move these projects forward.
Thank you. Well, that was great. I really appreciate everybody taking the time to come and to give their thoughts. I don't see any more questions in the chat, so if nobody else has anything to say, I think
I was
we
going to
can.
say one
Yeah.
other thing, when it comes to educating, and the PHA was mentioned with FAR. I think a bunch of us are on that SLC, but I think our education from the PHA also probably should be a little bit stronger, and purposeful as far as getting people to do this, just to risk assess. I think most of you guys have heard me say that I don't really care what you use as long as you just use it consistently. But I think in North America, it makes sense. And if you have all the data, I mean, I just think that the one equation that allows for missing data and has moved sort of forward is REVEAL Lite 2. So I think it's okay to be biased. I think we're not taking enough of a stand, but I do think that our patient, if it comes from the patient, I mean, I think that ends up meaning a lot. And they often want to know their scores. So I think it also keeps them engaged. Somebody said, I'm going to be what? Nagging?
Lucilla, just unmute. You are definitely not a question writer person.
Lucia.
Hello. I mean, I didn't want to, interrupt this beautiful debate, which has covered most of the topics that were really relevant to this discussion, really. You know me, guys, so I just wanted to ask about comorbidities. I know that it's not something that anybody wants to bring up when we're talking about PAH, but, it is something that some patients have to deal with. And so my question is, do you think that at some point in the future, comorbidities should be part of a risk assessment score, whether it's like 1 or 0 or more than 1 or something more defined? And what happens to those patients who develop comorbidities during their clinical course? Because now these patients thankfully live longer. And so sometimes they do develop comorbidities. So what do you think is the relevance of that, if any?
Yeah, that's an interesting question, Lucia, and I can give you a little bit of insight from the studies we've been doing with this FDA data set. And again, remember, this FDA data set is a very uniform population of trial patients. So again, they're not like registry patients, but when you look at this population and you put in comorbidities like hypertension, diabetes, hyperthyroidism into the equations, at the end of the day, all the comorbidities fall out, with the exception of renal insufficiency. And that's using multiple different statistical modeling systems. So in this, I guess, perfect patient population of trial patients, the comorbidities have little effect on the prediction algorithms. So again, I'm not sure how that will pan out in what we do in real life, because I do think we continue to misconstrue our categorizations of group 3 and group 2s as group 1s in the community, and I think that's where we're having a problem with the comorbidities.
Yeah, I think that the more comorbidities you have in medicine, the sicker you are. I think all of us that have been taking care of patients for a long time, our patients develop hypertension and high cholesterol and diabetes and just run-of-the-mill aging-related comorbidities. But I haven't seen the ones that were diagnosed with true idiopathic PAH that suddenly they don't tolerate their medications because of those comorbidities. Now, if you get uncontrollable hypertension and hypertensive emergencies, then, maybe you will develop pulmonary edema and issues. But I think that the comorbidities in itself, we know play a role in overall prognosis from the early REVEAL paper that Abby wrote. I think that do we need it in the risk score? I'm not surprised that it falls out because the other stuff is more disease specific, and probably takes into account the high risk aspect of things more than a history of hypertension. So it's an interesting question. I'm not sure that it's going to make a difference, but that's one of the things we can always look at. And yes, the patients that have multiple comorbidities at the beginning, the issue with the papers, right, that Steve just put in there is that, are they group 1? Yeah, I think a lot of times patients have other issues that are predominant and not PAH. And so it's sort of a mishmash, and hopefully PVDomics will help with that because I know we are still analyzing it. And I do think that there's going to be heterogeneity with medications because we don't do our studies on all these different medications. My hope is that some of our comorbidity medications actually help pulmonary vascular disease and we just didn't realize it.
Like GLP-1 agonists.
Like GLP-1s.
Yeah, I just threw a paper in the chat just looking at some comorbidities in this clinical trial data set with some caveats. I mean, in general, the drugs still seem to be effective despite some of the comorbs, maybe a little less effective. And number two, that this is a clinical trial data set. So even though they have comorbidities, they don't got comorbidities like in our practice comorbidities, right? They're still a clinical trial population.
They're not hemoglobin A1Cs of 11.
Yeah, so there may be a spectrum bias there, so take it with a grain of salt.
Yeah.
This is by Jude, who's also on the call, Jude Muccio.
I mean, the French registry just published their comorbidity data, and they showed the dual therapy is as good as they did fine with tolerating dual therapy in terms of outcomes. So
great.
Awesome. All right. Well, I think that might actually bring us to the end of this great talk. Thank you again, everybody, for coming. Thank you to Dr. Sahay, Dr. Gomberg, Dr. White, Dr. Benza, everybody for participating. And until next time, this will be the end of the PC Assembly Journal Club.
thank you. Have a great
Happy Valentine's Day.
Happy Valentine's Day.